This podcast is a presentation of UCTV.tv, University of California Television. Like what you learn? Help others discover UCTV podcasts by leaving a comment or rating in iTunes.
Begins with sort of what are aesthetics, and the definition of aesthetics is really a set of principles concerned with the nature of with nature and its appreciation of beauty. And so, what is the nature of beauty? And of course, that's an age-old question. But in facial plastic surgery and oculoplastic surgery, a lot of it has to do with restoring the youthful face. And so what we'll begin with today is sort of an outline of how do we understand the difference between the aging face and the youthful face. And then we'll focus on eyelids and the area around the eyes themselves and really try to understand what's going on with droopy upper and lower lids. And then we'll finish off with discussion on how we treat those. That's including botulinum toxin, Botox, fillers, and cosmetic eyelid surgery. So at this point, I would normally open this up to everyone and ask what's the difference? What are the differences that we see between these two halves of the individual? One is the youthful side and the other, the more aging side. And so we'll just kind of go ahead and point them out. And really, so in the youthful side, we see that there's, much smoother skin. The temples here are fairly filled out as opposed to being hollowed out in our aging face. On the youthful side, we see full, we call these the lateral meaning the outside fat pads on the brow, whereas as we get older, the fat underneath the brow starts to actually collapse and go away. We see a low medial brow, and we see the brow is arched laterally. And as we get older, a lot of times the medial part of the brow actually ascends a little bit, and the lateral part starts to descend, and so we lose a little bit of our arch. If we go down to, if we go here, the upper lid, again, it's fairly full and smooth, and the upper lid, as we get older, becomes more deflated, but also there's excess skin relative to that deflation. In the lower lids, we see that there's a very smooth junction between the lower eyelid and the contour of the cheek. Whereas as we get older, we start to see these grooves. We'll call this the tear trough that sort of separates out the contour between the lower lid and the cheek itself. As we get further down, we start to see the appearance of these lines, the nasolabial folds, what we call the marionette lines. We see lines, and we'll call them perioral rhytids. Rhytid just means line around the mouth. And in the youthful face, we don't see these. In general, we see a heart-shaped face in youth, and we see more contours, sometimes jowls, as we get older. So why does this happen? And a lot of it happens because there are changes that go on in the bone structure, the muscle structure, and the fat and the skin as we age. So back here, just in the skin, we actually see that the stratum corneum actually gets a bit thicker as we get older. There's more pigmentation that goes up into the skin. But we also see that the dermis, made up of collagen and elastin fibers, starts to actually break down and get much thinner. And so the skin itself becomes thin, becomes more wrinkly, and it starts to be able to stretch out more, and it doesn't have its resiliency. This particular protein called elastin is what gives all of our tissues the resiliency and the ability to sort of stretch out and then come back, and we start to lose that as we get older. I always think this is a fun picture to look at because this is just showing a little bit of the effect of sun exposure. So there's in addition to age, there's many external factors that can also sort of age our skin. So this is a former truck driver, and he would drive with the window open on one side and get a significant amount of sun exposure. You can see the effect of that sun exposure on just that left side of his face relative to the other side. There are a number of fat pads that sit just below the skin. And in youth, these are fairly robust. And as we get older, we start to see that these fat pads start to atrophy. They go away. And where they go away, our tissues become deflated. So we'll see deflation of the brow fat. We'll see deflation of the temporal fat. And so we'll see hollowing in these areas. We'll see deflation of a lot of this cheek fat. And because of that, you see the underlying structures, the bone and the muscles, which are not as smooth. This fat has a great smoothing effect to it. In addition to the deflation, there's also some descent of tissues. So we start to see there's migration. The cheek will actually migrate both down and will often migrate forward or anteriorly. And so that starts to create this groove between the nose and the cheek called the nasolabial fold. We'll start to see these grooves here along the bottom corner of the mouth. These are our marionette lines. We'll start to see that this nice round contour of the lid and cheek starts to separate out, and we see a groove start to set place between the eyelid and the cheek itself. Again, another picture sort of highlighting a lot of those changes that we discussed before. With respect to the eyelids, a lot is going on also as we age. And so this diagram is what's called a sagittal section. This is sort of cutting through the eyeball from the front part, right in front of the skin, to midway through the orbit. And what it is doing is highlighting the different structures that will be changing. So initially here we have the eyebrow up here, the eyelashes down here. This is the upper lid. We have skin. Then there's this orbicularis muscle. This is the muscle that actually closes the eye. Just deep to that orbicularis muscle is this fibrous tissue called the orbital septum. And the orbital septum is an important structure because it actually keeps a lot of this orbital fat back behind the eyelid. The same is going on in the lower lid. We see skin, orbicularis muscle, orbital septum, again, keeping the orbital fat back. As we get older, this septum starts to stretch out a bit more. We start to get a little bit of excess skin as well. Same thing happens in the lower lid. This septum starts to stretch out. However, it's adherent in certain places. So especially true in the lower lid, there's one place where the septum grabs onto this tissue called the periosteum right on the bone called the arcus marginalis. And in addition, there's a little ligament here that holds onto the orbicularis muscle called the orbital malar ligament or the orbital retaining ligament. And that's really very firm. And so you get this stretching of the septum. The fat is protruding forward. However, this ligament is holding it back and it's creating this groove along the lower lid. And so we see in this last picture, orbital malar ligament, we got some excess skin down here. The septum is pooching forward, and we start to see the upper lid and the lower lid bags that occur as we get older. But in addition, we have a number of changes going on even in the bone structure. So as we age, the orbital bones themselves are actually moving. And we see that the orbit itself is enlarging both superior medially, so it's in and up, as well as inferolaterally or down and out. We also find that the cheek itself is recessing. It's actually moving back relative to the orbit. As again, kind of showing this change, this is the youthful eye, more of a round-shaped orbit. This is the bone. And as we get older, it's stretching out superomedially and inferolaterally. and it's increasing this orbital volume. And what that means is it's allowing sort of the eye to sit back and look more deflated. And as we talked about before, these are X-rays kind of again in that sagittal view, but this is that cheek prominence, the malar prominence, and as we get older, it recesses and goes back, and we see that the orbital rim and the cheek are pushed back. And what that does is it actually provides less and less support for the lower lid. And in doing so, it allows the lid to fall, and it creates more of those hollows between the eyelid and the cheek. This comes up into play as we start to think about cosmetic surgery or fillers or Botox, because if we look at our youthful face, we have a pretty prominent, this is our cheekbone and this is our fat, and it's out in front of where the eyeball is, and that's supporting the lower lid really well. But as we get older, this cheekbone is starting to recess in. We're losing the fat, and the cheek is descending. However, remember, we still have that orbital retaining ligament. It's still holding true here. And so we start to get this groove in here, and instead of one single contour, we get two contours, which are disrupted by this groove. And also because this cheekbone is back further, it's not supporting that lower lid well, and that lower lid is going to start to fall. We call these the vectors. A positive vector is when the cheek is sitting out in front of the eyeball, and a negative vector is when the cheek is sitting back behind the eyeball. And in fact, it's this positive vector that's typically a very youthful appearance. Just to kind of give you a sense here, both of these folks here, this is our plumb line from the eyeball, and their vectors are a little negative, and this allowing their starting to become hollowed out in here, and we're starting to see these lower lid bags. This young woman is actually only in her early 20s. However, because she has a negative vector of the orbit, you're starting to see the lower lids protrude a little bit. Here is that little indentation. That's where that orbital retaining ligament or the orbital malar ligament is holding those tissues in. So as we talk about aesthetics of the face, a lot of times we were kind of brought up with the idea that, we should just lift everything, but higher and tighter are not always better. And this is just a number of pictures of some celebrities I found from the internet. And clearly, higher and tighter, it doesn't really necessarily look natural. And a lot of this has to do with the volume. And we've talked a little bit about deflation of the cheeks. And so we'll talk about a couple concepts. One is the double OG. So an OG is an architectural term for this sort of somewhat S-shaped figure. We see it a lot in doorways throughout architecture. But a number of aesthetic surgeons talk about the double OG of the face. So the first OG, and this is when we look at people from not exactly a side profile, but an oblique profile, we see that the first OG is this prominent lateral brow. So as in youth, the brow actually extends a little forward, and then it comes in, and that's the end of the first OG at the lateral canthus here. And then there's the second OG is when we have this nice smooth contour of the lid cheek, and then it kind of comes in again in that heart-shaped of the mid-face. Now, I love this photograph because the photograph on the left here is actually her pre-photograph. This is before she did any aesthetic procedure, and here's the post. And really what you're starting to see is that initially, she doesn't have a fairly prominent OG. She's got, a little bit of, a fairly flat brow, somewhat flatter cheek. Here, she's had some filler, had some fat injection to the brow itself. And that's plumped that out, given it a more youthful appearance. She's had filler or fat injection to the cheek as well. Hasn't had a blepharoplasty. This is mostly done just with filler. She probably had a little bit of Botox to her forehead, which has helped some of the wrinkles on the forehead here. So let's talk about the eyelid itself. So normally we'll get, as eyelid surgeons, we'll hear people complain about their upper lids or their lower lids, and we'll often hear they're unhappy with excess skin of the eyelid or the fact that the skin is protruding past the eyelid itself, and there's this hooding out here. They'll often say, my lids just look tired or sad or heavy looking. They may have difficulty wearing makeup. Sometimes this interferes with vision or activities of daily living or recreation. Lower lids, we'll often hear stories of, I have bags under my lower lids or bulges or loose skin. They're just unhappy with them. And again, this is that anatomy, which we kind of discussed earlier. This is a little bit of highlight. It kind of shows a little bit better. Again, here's that lower lid septum. Here's the orbital fat. Here's that retaining ligament. And remember again, as we age, the orbital septum starts to thin out. The fat moves forward. It's not that we have more fat in our lower lids. They're not bulging because there's more fat, but because the fat's not being held back as well. And we have that orbital retaining ligament, the orbital malar ligament, that's holding the orbicularis and the skin in, and it's creating that groove, allowing the fat to protrude over it. Upper eyelids have a number of reasons, though, why that can be droopy. And a lot of times people have some component of more than one of these, which may be playing a role in their appearance. So the first one is called dermatochalasis. Dermato meaning skin. Chalasis is usually sort of excess of it, sort of redundant. And what we see here is that there's actually redundant skin of the upper lids. There's some redundant skin in the lower lids. There's that bulge of the fat pad that's not being held back by the orbital septum. And you see this groove right in here. This is that groove that's created by that orbital malar ligament that's holding the skin and orbicularis muscle back. Here again, all that skin that's covering over the eye. And for this person, they're actually saying, I'm hitting my head into cabinets. I can't see. Having trouble driving. I'm having trouble reading. When we look underneath the lid, we can actually see that, the eyelid itself is probably at the right height. It's just that there's so much excess skin here. Same thing with this individual. A lot of excess skin. It's really starting to block their views above and to the side. The second cause is called blepharoptosis or eyelid ptosis. Ptosis just means drooping, so you can have ptosis of any structure of the body. In oculoplastics, we talk about ptosis of the eyelid. And what happens here is that there are muscles that raise the eyelid, the major one being the levator and the levator aponeurosis. And the levator muscle, often with aging, will actually stretch, and what we'll call it dehiscence or stretching of that muscle. And as that muscle stretches, it just doesn't hold the eyelid up as high as it should. The muscle works fine, it's just stretched out. A lot of times we'll see this, especially in younger individuals, if they've worn contact lenses, especially hard contact lenses, as the lenses themselves or putting the lenses in and out will actually stretch out that muscle more and more. We'll see it often in younger individuals if they've had prior surgery for the eyes as well, because sometimes that act of stretching the eyelids for the surgery itself can cause the ptosis. But here, if you notice, there isn't really excess skin. It's just that the eyelid itself is low. And then the last cause for droopy lid is eyebrow ptosis or brow ptosis. And a lot of this can happen because maybe chronic overaction of these muscles that are bringing the eyebrow down and in. These are caused by the corrugator muscles and the procerus muscles, but also the lateral brow. This area of the skin and the brow itself can sometimes just fall with aging as well. One of the clues that this is brow ptosis rather than dermatochalasis is that we can see that the hood actually extends past where the upper lid and the lower lid come together at that lateral canthus. When the hood extends past there, typically it's the eyebrow that's causing the trouble. Again, just an example of brow ptosis. This woman, here's her medial brow, and we can see that where normally the lateral brow should be at around the same height as the medial brow, her brow has started to descend, and it's actually gone down over a centimeter, and it's causing this brow to be low, and it's obstructing her vision. So a couple years ago, we started to really get into understanding the anatomy of what's happening as we age with respect to the brow. And so this article came out, I think it's like 2010, and we looked at a couple different measurements of eyelid height. We looked at the measurement from the lower lid to the bottom part of the brow. We looked at the measurement of the pupil reflex, the center of the pupil, to the upper lid, and a number of other measurements. And kind of what we found is that as patients were aging, contrary to sort of what was thought, is that the eyebrow itself, this height, the eyebrow didn't descend really as we age. It actually got a little higher. And you say, well, that's kind of funny if we think everything is sort of drooping and falling with age. But what we did find was that the eyelid itself was actually getting lower and lower as we age. And so it's sort of illustrated in this photograph of, it's the same woman, just when she was younger, when she was older, and it shows her brows and her eyelids. And you can see, again, she's probably painted on some of these brows to some extent, or she's drawing on some of it because the brow has been lost over time. But her brow actually is higher than it was when she was younger, but that's probably mostly in compensation for the fact that her eyelids themselves are lower than they were when she was younger. So she has eyelid ptosis, and her brows are going up actually to compensate. And that's often what we actually see in normal aging in the central and the medial part of the brow. The one area that doesn't seem to obey that is this lateral brow. Often that does seem to fall with age. And the reason we think that is there's a muscle that raises the eyebrows called the frontalis muscle. And that frontalis muscle doesn't actually extend the entire length of the entire horizontal length of the brow. It actually extends only to the sort of medial, the inside 2/3 of the brow, and then it sort of trails off. And so the frontalis muscle lifts the brow. However, we have so many other muscles that are bringing the brow down with time. We have these corrugator muscles that are bringing the brow in. We have the orbicularis muscle, the muscle that closes the eyebrow, closes the eyelid, that's bringing it down. And we also have the temporalis muscle that's bringing the eyebrow down as well. And so without any opposing forces in the upward direction, that brow with time continues to fall and stretch inferiorly. So again, still interested in this, we did a study looking at 1,024 subjects, multi-ethnic study, and we looked to try to see what was happening with respect to age and ethnicity. And we started using a couple additional measurements. One was looking at the lateral brow. So we drew a line from the very tail of the brow down. We call this the lateral brow plumb line. And then we looked at the angle that the brow makes from the center to the lateral brow. And that's the angle from the mid-brow to the lateral brow tail. And what we found was that the lateral brow plumb line as we get older, the lateral brow descends for both men and women. And we saw that in all ethnicities, this also was the case. Same with the angle of the brow. So as with age, that angle actually decreased. The tail of the brow is getting lower with respect to the middle of the brow. And again, we saw that the same held true. Little differences between ethnicities and races, but again, for the most part, was holding true throughout. The one thing to always remember, especially as we as surgeons, as we're thinking about doing reconstruction, is that the male brow is typically very different from the female brow. Classically, the male brow does not have an arch like the female brow does. It's typically lower. It rests at the orbital rim. It tends to have a flatter contour and maybe more prominent and fuller. Unfortunately, a lot of times when people do get plastic surgery and reconstructive surgery, they may not kind of take that into account. And so, especially here with Kenny Rogers, where, Kenny had these very low, flat brows, and, he had aesthetic surgery done and to raise his eyelids, or to treat his droopy eyelids. But what he got is a brow lift, which elevated his brows, but kind of unnaturally so. What he probably needed was a ptosis repair. He's got eyelid ptosis, and that's why his eyelids are still droopy. And so it's really important that aesthetic surgeons understand the various components: the brow ptosis, the dermatochalasis, the eyelid ptosis, when doing reconstruction, and keeping that in mind as we want to restore people to the youthful appearance, not necessarily give them a cosmetic surgery look. Okay, why don't we break for a question or two, if we have any?
We do. We have a couple of questions. So the first one is referring, I think, to that before and after picture from that first section. So when a person has some of the procedures that you described, what are the consequences 10 years after?
Oh, of any of these procedures?
Yeah, you might get to them individually, but yeah.
Yeah, so consequences 10 years after. So in general, usually I tell people, all of the same trends. So, we continue to deflate. Our skin continues to stretch out a little bit more. So all of that's going to continue even after we have our aesthetic surgeries. Probably one of the things that always comes up is, can you do something now that looks great, only 10 years later, 15 years later, find out that it doesn't look great anymore, and maybe it's causing harm. And where we often see that the most is when we're doing lower lid surgery. And what happens is, if we end up taking too much skin from the lower lids, or taking too much fat from the lower lids, it may be fine right after surgery, but as we age more and other tissues continue to stretch out, that lower lid can start to get lower and lower, and we can start to get what's called eyelid retraction, where the lid starts to hang down, and that then would have to be corrected or resuspended. The eye can become really dry and irritated from that sort of thing. And that's probably the most common sort of bad thing that can happen 10 years later that we see. And we'll probably address it more as we get into the cosmetic surgery part too.
Great. And then another question regarding visual field testing. When you're doing it for ptosis or dermatochalasis, can patients be mistaken for at risk for glaucoma due to blind spots or dark spots from brow or eyelid ptosis?
Yeah, it happens all the time. So I actually love my glaucoma colleagues so much, because a lot of times I get a number of referrals from them, because people do come in and we'll have a visual field test. So, and I don't know if we want to discuss visual fields a little bit. Just, these are things that people will do for testing for glaucoma, they'll sit in a machine. Their eyebrows may be droopy, their eyelids low, they may have ptosis. All those things can actually block the upper part of the visual fields, and it can look very similar to damage from glaucoma. And one of the things that we'll do then is we'll actually tape up the upper lid, kind of keep it more of an open position, and then retake that visual field. And if we find that there's actually a significant difference, A, that'll tip the glaucoma specialist off that this is not glaucoma, but B, that's often part of the medical indication to do surgery to raise those lids, is to sort of help that visual field, because it often will allow you to see better when you're driving, allow you to not get as tired when you're reading, or not bump your head into cabinets when you're doing dishes. So when I was doing my training, finished my fellowship in 2009, the top aesthetic procedures in 2009 were doing botulinum toxin A, doing filler, so hyaluronic acid, and then laser hair removal, microdermabrasion, chemical peels. So really, Botox and fillers were the number one and number two non-surgical procedures in that time. Fast forward to 2018, we've more than about tripled the number of Botox procedures that we're doing. We're still doing a fair amount of fillers, chemical peels, laser hair removal, dermabrasion, and further down the list. So these are still our top procedures that are done. In terms of surgical procedures, all plastic surgery, not just oculoplastic, breast augmentation, liposuction are 1 and 2. However, blepharoplasty comes in third, cosmetic eyelid surgery before nose surgery and abdominoplasty. And so the next part of this talk, or the second half of the talk, is really going to be devoted to what can we do to treat these aging changes, both the minimally invasive and the surgical. And really for minimally invasive, I'm going to talk mostly about botulinum toxin, neurotoxins. I'm going to say Botox, although there's a number of different neurotoxins that we can use. And then fillers, hyaluronic acid fillers, fat, other fillers, we'll talk about those as well. And then we'll actually get into some of the techniques of how we deal with ptosis and dermatochalasis surgically. So Botox is actually a brand name. It's just like Kleenex for facial tissue. It was initially discovered in 1793 as foodborne botulism. And it was associated with spoilage of sausage and named botulism after the Latin word for sausage, or botulus. So it comes from a gram-positive rod. It's the bacteria that's found in the soil. It's spore-forming, anaerobic, and it produces this toxin that causes botulism. There are 7 neurotoxic subtypes of botulinum toxin, labeled A through G. And we end up using botulinum A for cosmesis. In 1980, so a good little bit of San Francisco history. So Alan Scott, one of San Francisco's pediatric ophthalmologists over at Smith Kettlewell, he uses botulinum toxin for the first time to treat strabismus, or eye muscle deviations. He then uses it in 1985 to treat blepharospasm, where the eyelids are closing too much and they're spasming, and this relieves patients. And until that point, patients with blepharospasm essentially could not be treated at all. There was nothing we could do for these patients. In 89, Oculinum, which was Alan Scott's first name of the Botox, was FDA approved for blepharospasm, strabismus, and for hemifacial spasm. Allergan bought the company, renamed it Botox, and here we are. 1990s, there begins cosmetic use by Carruthers and Carruthers. Incidentally, Carruthers had spent time with Alan Scott early in her career, got introduced to botulinum toxin really early in its development and use brings that back to Canada, and the use of botulinum and for cosmesis stems from there. So how does Botox or botulinum toxin work? So we inject Botox and we inject it into muscles. And the reason we do this is that we have nerves interact with the muscle cells at this place called the neuromuscular junction. And when we bathe this area in Botox, the botulinum toxin gets taken up by the nerve side, so the nerve cell, through these what we call endocytotic vesicles. The light chain of the botulinum toxin is cleaved, and it exits the vesicle. And then it actually cleaves this protein called SNAP25. And SNAP25 is critical for the vesicles, the synaptic vesicles that contain acetylcholine. Acetylcholine is a neurotransmitter that causes, that allows nerve cells to cause muscle cells to contract. It's what the impulse for firing the muscle cell that comes from the nerve. These acetylcholine is normally released into the synaptic junction, but if you cleave SNAP25, you block this nerve's ability to release acetylcholine. And so the nerve itself no longer releases any acetylcholine, and that muscle doesn't fire. And you can imagine how systemically in systemic botulism, so we have massive amounts of botulinum toxin in all of our muscle, all of our synaptic junctions throughout our body, especially in our diaphragm where we're breathing, et cetera. This can easily kill the animal, kill us. But used very small amounts in very precise places, this can actually cause those muscles not to fire. And that becomes really important as we try to treat wrinkles and we try to lift certain tissues. On the market now, it used to be just Botox. Now there's also Dysport, Myobloc, Xeomin. They're all very similar. They have little bits of difference in terms of how quickly they act, how easily they diffuse. For the sake of our conversation today, the one thing to know is probably that there's no exact dose conversion between the different formulations of botulinum toxin A. However, roughly, most people will use 1 unit of Botox to about 1 unit of Xeomin to about 3 units of Dysport. Dysport was used in Europe around the same time it got approved in Europe as Botox got approved in the United States. And so a lot of times you go to Europe, most of the folks there are often talking about Dysport because that was the first botulinum toxin that they were using at the time. So in terms of contraindications, we'll never inject someone if they've got an active infection at the site or if they have any hypersensitivity to a component of the product. So obobotulinum toxin A or Dysport should not be given to patients who have true allergies to cow milk protein because there's actually cow milk protein in it. But this limitation doesn't apply to onobotulinum toxin A or Botox, or incobotulinum toxin A, Xeomin, or Myobloc, which is the botulinum toxin B. It is a class C agent in terms of pregnancy and lactating, so we generally avoid injections. And if we're doing this for cosmesis, we absolutely avoid injections in pregnant women. In the risks of maternal infant transmission of botulinum toxin in lactating women are unknown. Thus, we really avoid this use in this population. So whenever I start injecting someone with Botox, I always talk about the rules of the threes. And this is to sort of set expectations. It usually takes about 3 days for the effect of the Botox to start. So on the day we inject, there is really no difference in these muscles. And it takes 3 to 5 days to set in, and it peaks at about 2 to 3 weeks. So we're going to see the biggest effect from this Botox in 2 to 3 weeks. We're also going to see if there's any side effect. We get a droopy lid, or there's a part of the mouth that droops a little bit because we're a little over aggressive with our treatment. That's going to be most prevalent at 2 to 3 weeks as well. Usually that starts to back off a little bit, and then we plateau for about 3 months. And by the end of 3 months, little buds on these nerve cells have grown back, and we start to release acetylcholine again, and the muscle starts to work. And at that point, if we want to retreat, that's when we do. We can see bruising at the injection site. Sometimes we can get pain with injection. A lot of times I'll actually use a topical anesthetic cream first for people who are very sensitive to that. We'll sometimes also reconstitute the Botox with bacteriostatic sodium chloride, because that tends to be less acidic than the preservative-free sodium chloride. Some people will get a headache right after receiving the Botox. It's usually 1 or 2 days after the injection. However, what we found early on as we were doing this was that people with migraines, their headaches would go away when we gave them injections of Botox in their glabella areas. And so a lot of times people will use this to treat their migraine headaches, or they'll do it for cosmesis, but they'll get the added effect of migraine relief. And rarely we'll see, sometimes people get a little flu-like illness for a day or two after the injection. Probably the most important complications to think about is that the Botox can diffuse into the nearby muscle fibers. So it can get into muscles that we didn't want to treat. So it can cause a droopy lid or a droopy side of the mouth, etc. If we give too much, if too high a dose, we can see more of these complications. And again, in the neck region, if we inject too much, we don't know where we're injecting, we can actually have more serious or even fatal complications in that area. So the first area that were approved by the FDA to treat cosmesis were the glabella areas. This is the area between the eyebrows. And that's to treat the muscles, the procerus, which is the muscle that brings the eyebrow down, and the corrugators, which bring the eyebrows down and in. And then the second areas to get approved were what's called the crow's feet, or the lateral facial rhytids. And these are the laugh lines out past the eyelid here. And you can see this is this patient before they got treated with Botox, sort of with maximal scrunch. And then here we see these tissues are really relaxed. We see smoothing out of these lines in both areas. There are a number of places that we can treat with botulinum toxin, and it really depends on what we're trying to achieve. So one concept to kind of talk about is something called dynamic versus static wrinkles, or dynamic lines versus static lines. And dynamic lines are the lines that occur when we flex certain muscles that are underneath that skin. And so we will see dynamic lines in the forehead when we raise the eyebrows. We'll see dynamic lines in the glabella when we scrunch our eyebrows together. We may see dynamic lines in the lateral orbicularis area. These are the laugh lines or the crow's feet. Bunny lines if we scrunch up our nose, and perioral rhytids, they used to be called smoker's lines when we purse our lips. But we can also use Botox to reshape or to lift structures too. So any muscle that brings the eyelid down, or the corner of the mouth down, we can actually paralyze that muscle, so the opposing muscles that bring the eyelid or the corner of the mouth up act unopposed, and we can kind of get a little bit of lifting of these structures. So many times we can lift the lateral part of the eyebrow just by injecting botulinum toxin in the orbicularis out here so it doesn't bring the eyebrow down. We can lift the corner of the mouth by injecting into the depressor anguli oris here so that this muscle doesn't bring the corner of the mouth down. And I like this photograph because all of the elevators, these are muscles that bring tissues up, are in green. The depressors are in red. And it turns out if we focus on Botoxing, paralyzing the depressors, we can often lift these structures. We can lift the brow, we can lift the eyelids a little bit by using Botox. We talked a little bit about glabellar rhytids. So a lot of times we'll use a pattern where we'll treat the corrugator and the procerus here. We'll do a little less as we get to the tail of the corrugator because we don't want it to cause the eyelid to droop. And we'll put a little bit of Botox just in the orbicularis at the lateral portion of the brow, and this will raise the entire brow up. This is before and 3 weeks after Botox into the glabella. Notice these lines here have really kind of disappeared. It may take actually a number of months for these vertical lines, the number 11s, to go away. I've seen it up to 6 months of continued paralysis to fully relax that skin. This was talking about the temporal brow lift that we just talked about. And the study was done by one of our colleagues, former UCSF facial plastic surgeon, Corey Moss. And Corey found that you could actually lift the eyebrow about 4 millimeters just by using Botox, especially at the lateral canthus. To get rid of these lines, we can kind of treat the forehead as well, using a little bit. I don't treat the forehead a ton because I often find that if we treat the frontalis, remember the frontalis is what's lifting our brows. And so if we treat the frontalis, sometimes our brows can actually descend and we can get droop of our eyebrows and our eyelids a little bit. So I find that I treat this area probably much less than I did early in my career, just because I get such a great effect if I treat the glabella that a lot of times people aren't raising their eyebrows quite as much when they have this glabella treated. One thing we want to avoid is sort of giving people these super high arched brows. You know, if we Botox out here and we Botox our brows here, we can often get sort of descent of the brow here, and it becomes very high and arched out here. We can treat this easily. We can kind of add a little Botox right over the brow. We can cause it to fall back down. But we try to avoid these kind of complications. Another complication is a droopy lid. Sometimes with too much Botox, especially as we get out into the tail of the corrugator, it can cause that lid to droop. There are some drops, especially there's a new drop on the market now that people can use, and it can typically raise that lid back up a couple of millimeters as we wait for the ptosis to resolve. For our lateral lines, we'll put a couple units of Botox here just underneath the skin, and that will often cause those wrinkles to relax. We can treat the bunny lines and get rid of these wrinkles here. The lower face is often fraught with issues when we treat it with Botox, but we can use it to sometimes improve these downward lines. So again, there's a muscle called the depressor anguli oris that will bring the corner of the mouth down. And if we Botox that muscle, it can kind of bring the corner of the corner of the mouth back up. However, if you kind of notice down here, it's really a complex structure of a lot of different overlapping muscles, and they all do different things. So, you know, in red, we have this depressor anguli oris, but in purple here, there's the depressor labii, and they're really close together. And so, you know, if we end up treating the depressor anguli oris and a little bit seeps over to this depressor labii, we can actually get complications where the corner of the mouth is actually up too high. This is actually the complication side where the depressor labii was hit, and so this corner of the mouth is up relative to where it should be when she smiles. How do we treat that? Well, we'll just actually knock it out on the other side and then wait for both sides to normalize. A dimpled chin, we can often treat with a couple units of Botox into the mentalis muscle as well. And we can also treat these fine lines around the mouth with some Botox. We can also use it to decrease sort of squareness of the jaw, treating the masseter, which is a very large muscle in the face, over time will actually allow more of a chiseled face and decrease some of the squareness of the jaw. We can also treat the platysma bands. However, remember, this is an area that we do want to be careful of because of other structures that are important for the airway. Some finer points, we can help folks with a gummy smile to sort of relax some of those muscles that are bringing the lip up too much. So let's see if we have any questions.
We do. And just going back to that, we can do this one first if you want, just the OPMD, that was oculopharyngeal muscular dystrophy, and just about the treatment. I don't know if you want to touch briefly on that, and then we can go to the rest.
Sure. Oculopharyngeal muscular dystrophy, just for the rest of the audience here as well, is an inherited form of a muscular dystrophy where the levator muscle, as well as other extraocular muscles, don't work as well, and they gradually work less and less. And what we find is that treating those folks, our standard surgeries, which is often what we call levator surgery or conjunctivomular muscle repair, these are surgeries a lot of times that work really well when people have a normal functioning muscle that's just stretched out. However, with oculopharyngeal dystrophy, it's not stretched out, it just doesn't work as well. And because it doesn't work as well, those standard treatments don't work either. And so a lot of times what we'll do is we'll couple the eyelid to the eyebrow using something called a frontalis sling, because the frontalis muscle actually does work pretty well. And so by coupling that, we'll actually, it allows people to use their eyebrows to raise their eyelids. In addition, because the eye muscles that move the eye up and down, left and right, don't work quite as well, we often want to make sure that we avoid surgery that's going to put their eyes at risk, because normally when we close our eyes, the eyeballs actually roll up. It's called the Bell's response. But individuals with OPMD often don't have as good of a Bell response. And so we actually have to be really very conservative too with our ptosis repair, because we don't want to overdo it, because if the eye is open even just a little bit, it can sometimes expose the cornea and cause that cornea to dry out and even get infected. So a lot of considerations that we do differently for folks with oculopharyngeal dystrophy or myotonic dystrophy or some of the other muscular dystrophies.
Great. A couple more. Is it common for ophthalmologists to have some background in these procedures, or is it more of a specialty?
It used to be probably more common. Everyone who trains as an ophthalmologist gets training in doing these procedures, but I would say far and away the probably most common surgery procedure that we do as ophthalmologists in our training is cataract surgery. And then the other surgeries that are more specialized, like retina surgery or oculoplastic surgery, especially some of these nuanced type surgeries, are probably more now in the realm of the subspecialist than the generalist. That being said, there's still a lot of general ophthalmologists who will do blepharoplasties or may do some ptosis repair, and may do some lower lids, but it's not as much as it used to be.
Great. And then a couple of questions on Botox. If you get Botox regularly, does that muscle become less effective over time? So do you need less Botox? And then just kind of along with that, what are the cumulative effects of years of Botox injections?
Normally it doesn't actually become less effective, although sometimes the muscles can be a little hypertrophic, meaning that they're a little big if they're sort of overactive to begin with. So, sometimes we'll see people with fairly thick corrugator and procerus muscles initially, and we start Botoxing them, and those muscles will sort of thin out a little bit, and they'll be a little more atrophied just because they're not being used quite as much. They're not getting their workout. That being said, once you stop doing it, the Botox that is, these muscles will start contracting again, and they'll start to become thicker again too. So you can get a sort of transient thinning of these muscles, but they're typically going to come back and work just as hard once you stop the treatment. And so that kind of answers, or that goes into the second question, which is what are the long-term effects? And now, we've been using this for about 30 years, and we really haven't seen any significant long-term effects of using Botox periocularly. Some people with time will develop either antibodies to the Botox or to one of the other ingredients that are in the Botox, which will make it less effective with time. We sometimes see that in people getting treated for blepharospasm or hemifacial spasm, that the Botox will just not work as well as it used to. But that's really about it.
And what are the drops that might raise eyelids up?
So it used, I'm recalling the brand name now, because it literally, I think it came on the market a couple of weeks ago. And I'll put it in the chat in a little while, but it used to be that we used something called iopidine all of the time, which is a drop that we use for glaucoma. And that works well, using it 2 or 3 times a day, but it starts to become less and less effective with time. And I'm blanking on the brand name of the new drop, but essentially it's the same active ingredient that was in Afrin, which is the nasal decongestant, which folks are now using they put into a drop formulation, and it's raising the eyelids. So I'll find that for you all in between.
Can look it up too. 2 more quick questions and then we'll move on. Can you use Botox to treat spontaneous asymmetric mouth grimace? It's the first one.
Yes, you could. Anything that, it's sort of a that's probably more of a tic type condition, but just like a blepharospasm or a hemifacial spasm, you can kind of use that Botox to treat those muscles that are grimacing. Again, being really careful not to overdo it so that you cause the whole side of the face to droop. And you may have to balance a little bit with the other side to kind of get good symmetry, but it can be done.
And then just to backtrack, I just looked it up. Is it Unique that you were thinking of, the drop?
Upneeq. Yes. Upneeq. Yeah.
It's UPNEEQ.
All right. Why don't we go? So fillers. In terms of injectable fillers, we can use a number of different things to fill these tissues. They're really meant to address volume loss, rebalance facial proportions, increase symmetry, and correct wrinkles and scars. And remember, before we talked about dynamic wrinkles, these are wrinkles that are underneath a muscle that's contracting. Fillers, on the other hand, we often use to treat wrinkles that are static. So the nasolabial fold here, which doesn't really change when we smile or do any other facial movements, it's still a groove. The tear trough, still a groove. The marionette line, which is still a groove. Those are areas we'll often treat with fillers. Super large number of options that we can use to fill the skin. Probably the oldest one that people have been filling with is fat. It's from yourself. Trouble with fat is it often has a lot of variable duration. It has variable take. So often we'll take fat via liposuction type techniques from the belly or other areas of the body, and then we'll inject it into areas of the face. Sometimes it takes more in one area than another. It's a little less predictable that way, but it is very long lasting and it is your own tissue. Collagen used to be sort of the other alternative, and it was very short duration. People had to be tested to see if they had a reaction to collagen before they would get injection. But far and away, the most popular filler is hyaluronic acid. Hyaluronic acid is a substance that we all have in our bodies. It goes in as a gel. It's very forgiving because we can also melt it away. So there's a number of different hyaluronic acids available, and there's probably even more on the market next week than this week. And we'll use them throughout. And again, one of the reasons we use this is hyaluronidase, the enzyme that breaks down hyaluronic acid, is something that we all have on hand, and it's our friend. And so if we overfill one side versus the other, or if we get a little nodule from the filler on one in an area that we don't like, we can actually use this enzyme after we've done our injection to melt it away and to restore symmetry. In addition, if the filler material somehow gets infected, we can actually melt that infected filler away and treat it with antibiotics to get rid of the infection, as opposed to having to cut out filler that's infected. Number of different products on in the market. Some used for marketed more for sort of deep structures to sort of give more volume, like something like Voluma. Other areas that are marketed for more superficial lines, like Restylane Silk. They all, have little differences in terms of how they're cross-linked, which makes them either disperse a little more easily or clump a little bit more. Either go away faster or take a longer time to go away. Most of them now actually come with anesthesia in the filler itself. So you'll see things like Restylane L, which means that is Restylane, which is one of the older hyaluronic acid fillers that also has lidocaine with it. So it makes it a fairly comfortable process now, where it used to be that we would often have to inject people with lidocaine first and then do the filler. I always talk to people a lot before they get their fillers to kind of mention some things that we can prevent if we think about it ahead of time. So blood thinners, some people need to be on them. Sometimes we actually have to have a discussion that if you need to be on this blood thinner, maybe a filler is not necessarily for you, because the amount of bruising that you can get from filler injections may actually outweigh the benefit that you might get from doing the fillers. But if you're able to come off them or discontinue them 2 weeks prior, is often recommended. Some people have cold sores and other herpes infections that kind of chronically come about around their mouth or around their eyes. And if they have any history of these, we'll prescribe Valtrex, which is an anti-herpetic medication, starting a day prior to the filler, and we'll do it for 7 days, especially for lip augmentation, because this is the area we'll often kind of get a cold sore outbreak. And then when we're doing the procedure, we'll often prep the skin like we would for a sterile surgery to avoid infections and biofilms that are carried from the skin down into the filler and just kind of set in there and set up sort of this chronic low-grade infections. Number of different ways, and I'm not even really going to go into it too much, that we actually can inject the filler. We can push it ahead of us. We can slide the needle back as we're injecting. We can actually inject down deep into tissue, so be right on top of the bone to sort of create volume. We can fan our injections, or we can cross-hatch them to kind of get more diffuse augmentation of volume, as opposed to superficially, as opposed to a line of filler. There are a couple other types of fillers on the market other than hyaluronic acid. One is called calcium hydroxyapatite, or Radi-S. it is not dissolvable. It lasts a bit longer. These are essentially microspheres of like a coral type material. And, a lot of people will use it for hand. They might use it for cheek and chin augmentation. I tend not to use it anymore just because it's just not forgiving, and I can't melt it away if someone doesn't like the way it looks, or if it's a little uneven. We just have to let it go away, and it takes sometimes 1 or 2 years for it to go away. Polyallyl lactic acid, or Sculptra, is a different kind of filler. It's one that was approved for marionette lines, nasolabial folds, initially approved for lipoatrophy of the temples. And what we do is we inject it over a number of appointments, and it sort of builds up gradually. It actually causes your body to create a reaction that then builds up and increases the volume of these tissues, as opposed to the filler itself providing the volume. And it lasts for up to about 2 years. So let's just focus a little bit now on the common areas that we'll treat. So this person here has nasolabial folds. These are deeper grooves here. And we put filler underneath the nasolabial folds here. Probably a little bit of depot injection, a little deeper, and then maybe did some cross hatching, and that has decreased their appearance. In the area of the lips, putting a little bit of filler right at the vermilion border, the border between the pink part of the lip and the skin, avoiding this area here called the Cupid's bow, and then again, the vermilion border here. Same for the bottom here, really plumps out the lip, and it actually can decrease a lot of the wrinkles, these perioral rhytids that are around the lip. Again, with lips, I think it's super important to be really conservative, to improve it a little bit, but to not sort of get that really overly filled duck type appearance of the lip. I kind of have refused to do really massive lip augmentation because I just don't think it looks good. Cheek and nasolabial augmentation. So, it can really help appearance. So here, and again, she's also had some Botox. You can see that her forehead lines are also gone. But nasolabial folds, not only can we inject underneath these, but if we augment the cheek here and build out the cheek, it actually brings up and out the cheek, and it'll efface a part of this nasolabial fold as well. So part of treating this line is giving some filler to the cheek as well. In addition, when we fill this cheek, it actually fills in a little bit of this groove and helps the lower eyelid as well. And we start to get rid of that tear trough. This is just a nice article. It came out in 2011, which was one of the early articles to describe using filler to actually treat these grooves. Remember this orbital retaining ligament or the orbital malar ligament holding this tissue back, and people often will see the bulge of orbital fat above this line, and they're unhappy with it. But instead of doing blepharoplasty to sort of remove that that fat or displace that fat, we can actually just treat the groove itself. We can put filler, usually Restylane or something really thin, down on the bone here and bring out that groove. And it really does, and you can kind of see, help the appearance of these lower lids. None of them had blepharoplasty. They all just had a little bit of filler, and it goes a long way. And I would say for most of my younger patients, when they have that appearance, I'll usually talk them out of eyelid surgery, and we'll just do a little filler because I think it just works so much better. Like anything, you use it more, there's always a chance for more complications. Probably the most common complications are usually the ones that are not that serious, which are some tenderness and bruising, swelling, and those are really expected. And they resolve over a couple of days. And I always talk to patients about it, like tomorrow is not the day to sort of go to your high school reunion if you get filler today. Because it's going to be bruised and swollen. So, give yourself a few weeks to recover before going out and having pictures done and so on. We can get, as we spoke about before, infections of the filler itself. They can develop biofilms, often from mycobacteria, will give a late infection or a herpes activation. The most dreaded complications, though, are these ischemic complications of fillers. So it turns out that there's a very complex arterial supply around the face, and this actually extends to the area behind the eye as well. And so if we inject filler accidentally into one of these arteries and can keep injecting, potentially we can get filler that'll go retrograde and go back, and then can block any of these, as it pushes then forward, it can block the blood supply to the skin. But even more seriously, if it goes back so far into the central retinal artery, it can actually block the blood supply to the eye itself and cause fairly immediate blindness. So because of this, we actually always have our emergency kit with us. And the biggest thing, the most important one is to have is Vitrace, or that hyaluronidase. Because especially when it occurs in the skin, if we recognize it early and we inject a ton of this enzyme to break down the filler, it'll break down the filler even within those blood vessels. When it's behind the eye, people will often try and they'll do hyaluronidase injections to the orbit, but without a whole lot of success. Usually by that point, if it goes into the central retinal artery, it doesn't tend to recover from that. We'll often also give people aspirin to take because that may thin out some of the platelet response. So, to sum up fillers and Botox, we can address tons of areas of the face, the forehead lines, the glabella lines, the laugh lines, the bunny lines, the dimpled chin. With Botox, we can fill deep glabella lines with filler. We can fill the tear trough deformity, nasolabial folds, the perioral rhytids, marionette lines, the jowls. But we can also lift tissues with Botox. The lateral descent of the brow, we can treat with some Botox to the orbicularis there. We can treat the downward turned corner of the mouth with some Botox. I would say for lifting, though, fillers probably do the bulk of our job. We can treat the temporalis atrophy. We can treat lateral brow deflation by injecting filler underneath the brow. Cheek deflation, again, we can also treat that downturn corner of the mouth, and lip deflation. So I know we're running. How are we doing on time? We got one more section, but I want to make sure we have time for questions. Any new questions? Not really?
Do creams with hyaluronic acid also work?
Not anywhere to the same extent. Sometimes they can plump out the sort of dermis a little bit, so they can make the skin just a little bit plumper, but it's not the same effect by any means.
That is all I see in the Q&A, so I'll let you move on to the next.
Great. All right. So we'll talk a little bit about surgery. So, my preceptor, when I learned surgery, he was all about, measure 10 times, cut once, sort of the old adage. And it's really important that the marks that we put on the skin, all of our measurements that we do at the time of surgery is actually probably even more important than the actual cutting and the sewing, is how we mark. So in the upper lids, we'll actually always use what's called a pinch technique, and we'll figure out how much upper lid skin that we can take safely so that people can actually still close their eyes once they're done. And we'll always leave at least 20 millimeters of skin between the eyebrow and the eyelashes, because especially when you're lying on your back, the eyebrows go up, and sometimes that can cause a little gap if we're overly aggressive. And it's always better to underdo than overdo. So we'll mark the area of the skin. We'll mark first the eyelid crease, which is this bottom line here. We'll do our pinch, and we'll figure out how much upper lid skin we can take. And we'll remove skin, sometimes with or without a little bit of muscle. We may open the orbital septum, especially if it's really puffy in here and there's a lot of fat showing there. We'll actually sculpt back a little bit of this fat. And these are just some before and afters of patients who have had blepharoplasty. So all they did was they had a little bit of skin and maybe some fat taken to kind of improve their appearance. They didn't have anything done to their brows. They didn't have any TOSA surgery. And this is just with removing skin for these folks. 2 other before and afters for blepharoplasty, upper lid only. Remember this condition? This is eyelid ptosis or blepharoptosis. Probably the most tried and true is sort of the external ptosis repair. We make a small incision in the skin in that eyelid crease. We go ahead and then we dissect down to find that muscle, the levator muscle. And what we'll do is we'll actually pass a suture through the levator muscle and where it inserts on the tarsus, which is the sort of rigid part of the eyelid. And we'll actually accordion that levator muscle, and we'll bring it together. We'll tighten it a little bit, advance it in an adjustable fashion. And then what we'll do is we'll have the patient sit up. They're usually fairly awake while we're doing this, open and close their eyes, and we'll set the eyelid at the right height. And these patients all had levator surgery. This person had it on both eyes. This one just needed it on the left eye here and just had a levator advancement on the left eye. And it really does improve the appearance when this is the problem. In terms of lower lid blepharoplasty, remember we kind of evaluate the lower lids. Here, we say, okay, we have a deep tear trough. We have that line here. We've got some overhanging fat and maybe a little bit of redundancy of the skin on both sides. So in order to sort of address that fat, which is really usually most of the problem, is we'll actually go in from the inside of the eyelid. We'll make a little incision on the inside of the eyelid, and that gives us access to this area behind the orbital septum where all this fat is. And we can either trim that fat back, or we can actually displace that fat. So we kind of show you 2 different techniques. And here is going in through that conjunctiva. We're now accessing the orbital fat. We see, okay, here's our orbital fat, that nice yellow fat. And we can actually either trim it or we can create pedicles that we can then bring down into the cheek to actually fill that groove. So what we like doing a lot of times, because we know that people haven't lost fat, it's just been displaced, we'll actually release this arcus marginalis here and displace the fat and bring it down to treat the tear trough. So here we've released that orbital malar ligament, and we've taken our little pedicle of fat and we brought it down into the tear trough and into the cheek. And now that recreates that nice smooth angle. So before and then after. Lastly, probably one of our best friends is blending filler with surgery. So a lot of times we can use a little bit of filler here and there, especially hyaluronic acid, to just do the final touches, put the very sort of icing on the cake with our cosmetic procedures to really create a complete look after surgery. So with that, I know we're probably almost at time. Maybe we'll open it to any questions, and I'm going to stop sharing my screen.
Yeah, we have a few minutes. So first question, are there any contraindications for surgery or fillers if the patient has ocular rosacea?
It's not like an absolute contraindication, but I'll talk to people about it because ocular rosacea will often lead to prolonged healing. So it may take a lot longer for wounds to heal when people have ocular rosacea or facial rosacea. There can be just more inflammation related to the surgery itself with both of these things. Fillers probably not quite as much as the surgery itself. I see more of the issues when people are having surgery than fillers. And Botox, I never had anyone had problems with Botox and ocular rosacea.
Okay, and then what causes a droopy lower lid?
it could be a whole host of things, but the biggest cause is birthdays, honestly. So as we age, it's all of these structures, as we were talking about before. The lower lids descend, and then the cheek deflates, and sort of gravity starts to bring the cheek, this deflated cheek, now down and in, and so there's no longer, as it's sort of pulling down then on that lid. And then remember, before we talked about the bone of the cheek, as we get older, starts to regress, and so there's less and less support for that lower lid, and it starts to fall. In addition, some of the tendons, just like any tendons in our body, start to stretch a little bit more with time, and so we can actually get stretching of this lateral canthal tendon as well, and that'll allow the lid to kind of come down some.
Couple more. We have a few more minutes. If you have multiple eye issues like glaucoma, cataracts, etc., is there an order in which you should deal with cosmetic corrections like eyelid drooping?
In order.
Would you wait for the lid issues until you fix the other ones, I think is the question.
I think that's I always tell people, do all of your intraocular surgery first. Do all of dealing with your cataract, deal with your glaucoma surgeries. If you know you're going to get glaucoma surgery, you know you're going to get cataract surgery, put off the lid surgery. If it's like, oh, I have cataracts, I may have to have surgery in the next 10 years. Well, maybe then go for your lid surgery, and you can always revise things later. I think a lot of it has to do with how fast these things are coming up.
And regarding the Kenny Rogers photo you put up, how does that happen? Is that negligence or a patient request?
Who knows? Sometimes it can be all over the place. I hope you still have the photo of that you were going to present for us later. It can go either way. So sometimes, I don't know if it's negligence or it's just sometimes the aesthetic of the surgeon is different. Sometimes the patient kind of comes in with an idea, they want something, and you have to be really firm to, if it's the wrong idea, to talk them out of it, or to kind of present them with the right idea that's going to achieve their goals. Unfortunately too, I do think that sometimes there are surgeons out there who, a brow lift costs a whole lot more than a blepharoplasty. So, there may be a little bit of trouble with scruples as well.
What else? Is Voluma related to, is Voluma limited to cheeks, or can it be used safely to fill in a mild jowl line, or what filler works best for that?
So, I love Voluma for cheeks. The jowl here too, you could probably use it for, because again, it's going to be on the bone, so it can kind of help with that area. Basically, Voluma is great for deeper structures. If you're doing sort of really superficial, fine stuff like tear troughs or lips, it's definitely not for that, because it's just too thick. And you can get a lot more irregularities there. But for deeper structures, like you're talking about the jowl lines, some of these deep marionette lines, cheeks, Voluma is great.
Great. Okay, and then I will ask one last question. That's in the Q&A. How confident are you that you can always identify people who have had quote unquote work done?
If it's really good work, it's really hard to identify, because it was done right and it really restores the natural appearance. And it's easier to identify bad work, or work that wasn't really optimal. A lot of times you can see if someone's had a very faint scar. So we have the benefit of, here's this slit lamp right beside me. So I've got a microscope every time I'm looking at patients and I'm looking at their eyelids. So I can often find little microscopic scar lines, or little areas, when we flip the eyelid, that I can see that has a scar from, a lower lid blepharoplasty where they went on from the inside. But, if it's done tastefully, often it's really hard to recognize. And that's the mark of a really good surgeon and a really good healing.
Great. All right. I think we are at time, so I want to be respectful of everyone's time. Brian, thank you so much. That was really interesting. That was really informative for me, because it's not something that I do all the time. So
I appreciate it. Sorry, it was a little bit of a tour de force, but I figured if we had an hour and a half, we could probably cover a lot of ground. And I really thank you for being the MC and the host of hosts. And thank you to everyone on the attendee list and for coming and spending time with me tonight. And I really appreciate it.
Awesome. All right. Thank you, everybody, for joining. And then hopefully we will see a lot of you next week. Have a good night.
Bye-bye.
You've been listening to a podcast by University of California Television. For more information about this program or UCTV, visit us online at uctv.tv.